Okay, so I'm going to start us off with the first talk. So contemporary trends in non-medical prescription drug use as a function of individual and socio-demographic characteristics. And so this is going to be looking at individuals ages 12 to 65. I'd like to acknowledge my co-authors, Lauren Masters at Penn State and Ashley, who's a second presenter. So opioid overdose and death rates, as you all are likely aware, are the highest in the nation's history. The overdose death rate has increased really dramatically in the last few years, and over 70,000 Americans died from overdose in 2017 alone. Opioids are the main driver of this rate of death. They were involved in 68% at least of the deaths that were recorded in 2017. And the highest death rates have occurred in West Virginia, Ohio, and Pennsylvania, where we're from, was ranked number 3 in the country that year, Washington, D.C., and Kentucky. And these increasing rates are happening in many states. It's happening across age groups, racial ethnic groups, across urbanicity. And it's in particular, we're seeing this trend in opioid use and death increase among women and among those with private insurance and with higher incomes. And so it's a different type of trend in overdose deaths that our country has seen in recent years. And so prescription drug misuse is one important pathway to opioid use disorder. And so just to be clear, that when we're talking about opioids, we're talking about prescription opioids prescribed to address pain, prescribed by our physicians. We're talking about heroin, fentanyl. So those are the big leading opioids that we're dealing with opioid use disorder. Prescription drug misuse is the strongest risk factor for heroin use onset. So we've got to be thinking about this particular pathway as we want to address the opioid overdose death rate in the U.S. And so this figure shows the percentage of heroin-dependent individuals that started with heroin versus prescription drug misuse over history. So these are decades from 1960 to 2010. And so you'll see this crossover effect where the heroin dependent individuals much more likely started directly with heroin in the 60s, 70s, and 80s. We see the crossover effect in 1990s, and today, 2000s and 2010s, we see that it's much more likely that individuals are starting with prescription drug misuse. Those are medicines prescribed by our doctors for the intent of helping us address our pain. And so this phenomenon of heroin drug dependence is quite different over historical time. So where are the leverage points for prevention? That's the big question, right? So we want to understand better the precursors and correlates so that we can inform prevention. This figure shows the mean age of first opioid misuse among heroin users. So among those who are using heroin, who are heroin users, if they started in the 1960s, the mean age of onset was about 17. If they started in the 1990s, the mean age of onset was over 20. If they started in the 2010s, the mean age of onset of opioid misuse of any kind was almost 25 years old. And so we're seeing really important shifts, historical shifts in the phenomenon that we're concerned with today. We're seeing these very different socio-demographic shifts. And so our prevention efforts, we're very focused in this society on children and adolescents. Young adults are absolutely key, and so we really need to be thinking about prevention programming for young adults who are already out of the school ages. So the goals of this particular study are to examine prescription drug misuse and its correlates across the life course using contemporary national data. So first, we're going to look at weighted age trends in the behavior itself, prescription drug misuse. And then we're going to look at and test for age-varying differences in prescription drug misuse across sex, poverty level, urbanicity, and levels of recently experienced pain. So just a kind of a smattering of potential correlates of this prescription drug misuse, this key risk factor for heroin dependence. So we're going to be using the latest data from the PATH study, the Population Assessment of Tobacco Health and Health. That's Wave 3 is the latest release. So we are using those data. It's nationally representative data, a longitudinal cohort study of tobacco use and other substance and health behavior. This was a NIDA-sponsored primarily project. And it's an incredible resource, but we just grabbed the most recent data from Wave 3 because we want to get the most contemporary data possible to look at risk factors today. So these data were collected in 2015-16, and as soon as Wave 4 is out, we'll be able to replicate these same analyses. So we've got almost 26,000 adults, ages 18 to 65, and the mean age was 41. And you can see the distribution across sex and racial ethnic groups here is nationally representative. So what is our outcome of this study? It is past year prescription drug misuse. Did you misuse opioids, prescription drugs in the past year? And so I want to be precise here. We have 88.1% said yes, they have in the past year. That's 8.1% of adults ages 18 to 65 have done that behavior. The way that it was measured, and we can kind of come back to this in the discussion session, is past year use of prescription painkillers, sedatives, or tranquilizers. And so it goes slightly beyond opioids, the way that this was assessed. And so that's something we can talk about. But there are no prescription stimulants. It's painkillers is the primary one, and sedatives and tranquilizers. So that's the behavior we're looking at. The correlates we're looking at are age to the nearest year, age of the participant, their sex, poverty level. We organize poverty level based on the income to needs ratio. If it was less than 100% of the poverty line, they were coded in one category, and that was 27% of the population. 20% are in the 100 to 200% income to needs ratio, so they're also very stretched financially, living probably paycheck to paycheck, and then greater than 200% income to needs, so that's the upper half. So it's not high income individuals, but it's the higher half of individuals in our country. Urbanicity was an interesting variable to use. The way it was coded, as far as we could understand in the data, we've got this large group, which we're going to call urban today, but it's 95% of the United States. And so it's the not urban is the most rural individuals, the 5%, 6% most rural individuals in our country. And then finally, the variable for pain. Pain in the past 7 days on a scale of 0 to 10, the same kind of scale you do when you visit the doctor. We have 30% said 0, no pain in the past week, so they are not currently experiencing pain of any kind. We've got low to moderate pain. We put a pain threshold of 1 to 5 into the middle category, and those 14% of individuals who had reported 6 or higher on that pain scale we're calling severe pain for this study. So we've got 3 levels of pain, 3 levels of income, poverty level, 2 levels of urbanicity, and sex. Okay, so we're going to be applying time-varying effect modeling, a flexible approach that's a regression-based approach to examine age trends in these associations in the correlates of prescription drug misuse. So we did weighted analyses. All these analyses are weighted, and remember, we're looking at 18 to 65-year-olds. We will be taking a look at age-varying associations, so we don't want to know overall how are females more likely to use prescription drug misuse, but across every single age throughout this adulthood period, 18 to 65, what does that association look like? So age-varying associations between past year, autocorrect must have done PDF, prescription drug monitoring, PDM, with demographic variables, sociological covariates, and pain. And these analyses were all done in SAS. And so this is an example model that was fit. And so this is to estimate the age-varying sex differences. So you see the beta for the female predictor there in the log odds of prescription drug misuse. So we're looking at the effect of being female on the log odds of prescription drug misuse, but it's as a continuous function of age, and it's a nonlinear function of age. And so you'll be able to see the nuanced age trends in this association. So here is one of the results. So this is the difference between females and males, showing the difference in the weighted prevalence estimates of prescription drug misuse for females in red, males in blue, across continuous ages 18 to 65. And at the bottom of the graph, you'll see those yellow highlighted age ranges, and those are the age ranges where we have statistically significant differences in the weighted estimates between males and females. And so interestingly, we see in the very young adulthood, ages 27 to 35 or so, we see females are at higher risk of prescription drug misuse than males. And again, in around middle ages, around 48 to 58, we see again the women are using prescription drug misuse at higher rates than males. And then there's a trend toward a difference at the end, but it was not statistically significant. And so these are the differences. Again, this is, thinking about what are we learning here. This is in 1 year of historical time, recent year. What are the age trends? Who's using what? And what are the different characteristics associated with prescription drug misuse? And how could we think about targeting these populations? Here are the results for the prevalence of past year prescription drug misuse across those 3 income to needs categories. So we have the higher income half of our country, the green line, the 200% income to needs ratio or higher. We see that the rate of prescription drug misuse increases from ages 19 to 26. We know this, right, in the national estimates, and it is extremely constant across age after that. And so at no ages do we need to think about those individuals being at higher risk relative to lower income, or relative to other levels of income. What we see with the lowest income, so less than 100% income to needs, that's very low income, that's the red line. We see that we see very early at age 19, 20, 21, the rates are going up together, all the groups, regardless of their income to needs ratio, and we see that diverge. And the poorest families, the individuals are at the very highest risk for prescription drug misuse, and you'll see that's peaking in middle adulthood, mid to late adulthood for the red line at about 15% of that group misusing prescription drugs. And the yellow line is the intermediate level of poverty. And you see they look more like the poorest group than the higher income half of our country. And so I've got 2 more figures to show you. So this is the difference between urban and rural. And remember the way this was measured, it's the 95% that are in metropolitan areas or, small to large metropolitan areas and cities. And the green line is that 6% of the most rural individuals in our country. And so we see an interesting crossover effect here with age, where the most rural communities, these individuals are at significantly higher risk for prescription drug misuse around ages 39 to 46. And but in later adults, older adults, we're seeing that those most rural individuals are at lower risk relative to urban. And so thinking about the intersection between age and urbanicity in contemporary use patterns may be important. And finally, this is the pain variable. So this was by far the strongest association, as we might expect. And what we see is the significant differences between no pain and mild to moderate, and no pain and severe pain. It's significant, it's large effect, and it's across all ages. And one could show from this graph, you can see that around age 30, 32, these young adults who are experiencing higher levels of pain, that's where we see the biggest link between reported pain, and prescription drug misuse. And it's worth noting, too, that severe pain category, that red curve goes as high as about 27% of those individuals. So that's a very high rate. That's the highest rate we've seen in this talk. Okay, so in summary, females are at higher risk during young adulthood and midlife. We see significant effects of poverty emerge in the 30s, and they persist. The very rural communities seem to have higher rates in the younger adulthood and lower rates in older adulthood. And the link with pain is the strongest one we've seen, and it's stronger around age 30 and persistent across ages. I would say we still have much we can learn from existing data around how we can inform prevention efforts and targeting individuals. But we also are very interested in keeping an eye on emerging epidemics. Certainly we're concerned about some of the other drugs that we're seeing increases in recently. And also very important, and what the next talk will feature is we're seeing increased attention given to, and I believe increased engagement in polydrug use, co-use, and simultaneous use, where you're using two substances at the same time, so their effects interact within the person, but also there's the pharmacological interactions of the effects, which often are very, very risky for the individuals. And so I think a tighter look at that. And then new drug delivery systems, I think are driving substantial, rapid, recent change. And so we're keeping an eye on the electronic vaping devices. You can see trends from 17 to 18 in flavoring use alone, nicotine use, and vaping marijuana. And so these are very on the rise, and we're going to be keeping an eye on some of those. So thank you very much. I'll take a question or two now, and we'll have, again, time at the end for discussion. Questions? Yes? Yeah, let's see. Do you remember the results? So we looked at that very deeply. Part of it is some of the, as the groups are very differential in size, makes it really hard to make statements about statistical significance. We tried to look at it very fine-grained, where we had a lot of different racial ethnic groups, and so it looked very confusing to try to make sense of it. I think, and also we had this situation where there was like the other multiracial group that was very heterogeneous in what their compositions were, racial ethnic compositions were, and that group at certain ages had by far the highest rate of prescription drug misuse. And so hesitate to say, if you are a multiracial individual, you're at this highest risk, and really feeling the need to drill down before we report those results. If that's helpful. Yep.
I appreciate that.
Yeah, I completely agree. Thank you for those comments. And if a lot of our audience and our society here at Prevention Science is focused on programs like PROSPER and CTC, these community-based coalition models to prevent substance abuse, and it's been shown very, very consistently that it does produce lower rates, and the prevention works for opioid drug misuse and other drug use, but those have largely been done in more rural communities. And so this idea of modifying those programs to work well in communities that are more urban, maybe more broken and hard hit by opioid epidemic, I think is critical work for the future. So one more question? Yeah. Yeah, that's a great question. I mean, so one thing that we can do, and this was our first descriptive effort, but if we actually fit those models specifying a predictor for rurality, and what we can do is enter in other variables that we want to control for and see if that reduces the difference, that crossover effect that we're seeing in rurality. I'm not quite sure how to handle the mortality issue. These are weighted data, so it's representative of the relative populations, but if rural individuals are dying at faster rates at younger ages, then we do need to think about that. That might require, investigating administrative data in those communities, looking at the coroner's reported data at the county level to see if, in fact, we're seeing higher death rates. The death rate is on the rise in rural communities, faster than urban. So I think that's absolutely a plausible explanation. Yeah, thanks for that. Okay, let's move on to the next presenter, and then we'll have more time at the end. So thank you so much. Ashley?